from the Toronto Star. I'm Sabah Itazaz, and this matters. Being on the front lines of a war isn't easy, and being on the front lines of a global pandemic is nothing short of that. And one of the hardest hit battle zones against COVID-19 have been Ontario's long-term care homes, where the Canadian Armed Forces were deployed to help respond to a growing crisis. What came out of that was a harrowing report of terrible conditions, mistreatment, and abuse of residents in 5 long-term care homes in Ontario. In today's episode, we will get a first-hand account from a military frontline worker about how the forces responded to the pandemic and to the care and well-being of Canadians, and what can be done so that we don't need to call in the military for either a rescue or reconnaissance. Corporal Laila Ahmed is a Canadian Armed Forces Medical Assistant who worked at some of these long-term care homes and was part of what was called Operation Laser. She joins me now to talk about her experience there, how that changed her, and why she left her full-time job at that time as a registered practical nurse on the other COVID frontline to be a part of this operation. Hello, Corporal Lola. Thank you so much for making time for us today. I know you had a night shift in the ER.
Yes, I did. Thank you for having me.
All right. So I want to talk to you about your work first. You were in a way on both the civilian and military front lines during this pandemic. As a licensed civilian nurse and then a military medical assistant, what was it like being on the front lines of such an unprecedented crisis in both capacities?
To be honest, it's been an honor to be involved right from the very beginning. At the time, sort of that the pandemic started hitting the ground in Canada, I was working in the emergency room in Ontario. So we sort of got to see how we would react in the initial first stages of a pandemic and how we grew and made policies to ensure that we protected our patients and staff. And then when the opportunity came to deploy with the military, it was the same thing. I was happy to be where I was needed the most.
But could you ever have imagined you would find yourself on the front lines of a global pandemic?
I mean, I think that it's something that we learn about in nursing school. We look back on what's happened in the past, but I think there's a certain amount of invincibility that we have in modern times. So definitely not my plan in 2020, but we kind of roll with what we're given, and I'm happy to be taking care of people during this time.
And I hear you left your full-time civilian job to work with the military during the peak of this crisis. Could you talk about that and what led you to make that decision?
Absolutely. So the sort of drive in order to do that was a lot of support from my civilian management and our emergency room director and everything. So I couldn't have made that decision without their support. And I will say it was instantaneous support. I have a wonderful management team at the emergency room, and our emergency room director also was in the military. So when sort of they were queuing to see who would be able to go and respond to the hardest hit areas, I had a quick sit-down conversation with her, and she was immediately open and receptive to me going, despite sort of the challenges that it would present for the emergency room and backfilling those shifts as well. And then further from that, being able to join in and really use my skills and use my knowledge that I've accumulated over my nursing career. At the beginning, we didn't know that we were going to long-term care. We didn't really know until we went to board in Ontario. And that was late April when the request for assistance came out with the provincial government. So it was kind of, I know that we are going to be deployed wherever we're needed, wherever civilian healthcare is sort of requested. And it was just the willingness to be wherever the highest need was and wherever we'd be able to make the most impact.
So tell me a little bit more about the Operation Laser. It's called, I believe. Where did you end up being deployed?
Sure. So for Operation Laser, we were sort of trying to figure out in February, March, as things started to gear up, what direction we'd be needed in. But in terms of particularly civilian response, we wait to be called upon. So in this case, when the Ontario government called upon our Joint Task Force Central and our health services branch of the military to respond, we were still very, very fast moving. So it happened within a series of probably about 4 or 5 days between us being told, okay, this is finalized, there's a request for assistance, pack your bags, going up to boredom, making sure that everyone had the specific geriatric training that was required, and then deploying into the home. So we ended up being, at least our group, that first rotation. We were the first rotation in Ontario There was one prior rotation that was in Quebec, but we were the first rotation to enter the homes in Ontario.
Right. And you were deployed in some of Ontario's worst hit areas, like long-term care homes, facing unprecedented challenges during the peak of COVID-19. And we've all seen such disturbing accounts from the military reports that came out. What were you dealing with? Walk me through some of that.
I mean, anywhere that we go, whether it's an international theater or a domestic operation, we do have an obligation to report what we see and to report that unbiasedly and factually. So the report definitely describes a lot of scenarios that were troublesome, that required sort of a push up to higher levels and to the right people to ensure that action was taken. I will say as well, though, that what wasn't necessarily in the report was that there was a lot of excellent civilian staff as well, who were working for maybe 30 days, 40 days with no breaks, working double shifts, sometimes night shifts, like 6 or 7 shifts in a row, that when we came there, we were able to collaborate with, give them that break that they needed, fill in the gaps with the teaching that may be there, and then collaborate to make sure that we can stabilize the home and then eventually remove ourselves. So there was definitely some things in the report that I'm glad got passed up, but I think it wouldn't be fair if we didn't mention the work of the civilian healthcare practitioners as well.
Of course, right. There's both sides to that. So in terms of some of these facilities that you worked with personally, what stands out to you? What were you dealing with there?
I think there's a number of challenges I know that have been long-standing in long-term care homes. From the hospital side of it, we know that there's an extremely long wait for people to be able to go into the beds in the homes. And then there are some staffing challenges as well. And this is not something that's new. It's something that's pre-COVID. But I think working and operating under a pandemic model makes it even more obvious of why some changes are needed in that sense. So the challenges of just making sure that everyone has dignified care and equitable care and the time constraints that were put out, definitely it's sort of an eye-opener to see how hard staff normally work and where we need to support them a little bit better.
So you're speaking to a number of challenges here. When you're looking back at your time serving here, what are the things that you think you will remember the most about the whole experience? Tell me some of the people there, some of the interactions that you had with the civilian staff. Do you remember anything that affected you?
Absolutely. I think anyone would be lying if they would say that watching people who are unwell or who are struggling doesn't have a personal effect on them. Even as a civilian nurse, it always has had an effect on me, and that's how I know I'm in the right career. There was a lot, as we know, long-term care is sometimes the last home for people, whether it's COVID related or not. So being able to do a lot of palliative care work was extremely important to me, making sure that people were comfortable, that there was opportunities if families could either virtually visit or one person could visit in sort of those last moments, or making sure that people weren't alone. We were able, along with my amazing civilian and military coworkers, to ensure that whenever possible, we were there to spend sort of those last moments with people and ensure that they were as comfortable and pain-free as possible. And that really is an honor to be able to do. And it's something that's very special about the nursing profession and about our role in the long-term care homes.
And what was the most unnerving thing about what you were dealing with there? You're painting some painful pictures here. What do you think unnerved you the most?
I don't know necessarily that anything particularly unnerved me. I mean, I've worked as a nurse now for about 4 years. So I've been in some difficult situations, and you really get to see sort of the full life cycle from birth to death whenever sort of that happens to hit your patients. There are some concerns, I think, for me that I want to make sure that everyone is treated with dignity and respect. And on my firsthand account, I didn't see any issues. There were some maybe learning gaps and some concerns in terms of infection control that may have led further to the issues with managing COVID-19. But really, I think it's just making sure that everyone has a firm understanding of high quality patient care and safe and ethical patient care, and ensuring that people are given what they need to feel dignified in the last years of their lives.
Right. And you spoke to me about stress levels, about working these double shifts and just constantly being on the job during this crisis. The stress levels must truly be very high for you and your colleagues, finding yourself in the eye of the storm in a way. What was a typical day like for you every day working there?
So it really depends on sort of what stage. When we first hit the ground, we definitely hit the ground running. There was a lot that needed to be done right off the bat. And so we were working 6 12-hour shifts, days or nights a week, and then including stuff sort of we were debriefing and we were helping write up sort of our events of the day that would eventually be added to the report every day. So it turned out to be sometimes 15-hour days, and that included for night shift as well. I was on day shift, but night shift worked 6 12-hour shifts in a row, which anyone who's worked shift work will know that's quite exhausting. So those initial challenges there of fatigue were there, but we hit the ground knowing that there was people who hadn't had a day off in 30 days. And so we had sort of the drive to want to work that hard. And as things started to stabilize, we could begin to pull back and sort of shorter shifts and sort of shifting our shifts to ensure that we have the peak times of need covered. But at the beginning, the first 2-3 weeks, it was quite heavy, but also for good purpose because we needed to be there.
And we've seen one of the primary concerns during this time for frontline health workers has been their own safety as well, and dealing with the situation at the peak of the COVID-19 infection. Were there concerns and fears regarding your own safety and those of your colleagues?
So we ensured, so everyone who went out, I'll say this, already was a medical assistant. So we have 2 training courses, our QO3 and our QO4, and our nursing officers, they had their basic courses as well. So we weren't taking military members sort of right off of basic training and throwing them into this environment. The military members that were working directly with the patients or with the residents had some medical training already. But when we hit boredom, those 3 or 4 days before we deployed out to the home, we ensured that everyone really knew what they had to do, which means that proper donning and doffing of PPE, proper hand hygiene, we socially distanced at all times, we wore masks at all times. So there's always inherent risks. That's something that we accept as a healthcare provider, particularly when sort of the enemy, if you want to call it that, is something that's invisible. You could do everything right, and you could still end up with the disease, and we're not entirely sure all the time where we get it. But we know that there's certain measures that will help protect us, which is what we followed. Did it mean sometimes that it was lonely and a little bit isolating? Absolutely. But it was a force protection measure and ensured that we were able to continue to respond to the need that the homes had sort of put out.
We'll be right back. Dealing with, as you mentioned, taking care of sick people, dealing with death and loss and grief as well. This has to have had a mental impact, a mental toll on the healthcare workers that were there as well. There's the trauma associated with that. How did you and your colleagues cope with that? Did you feel some of that?
I mean, absolutely. I know I can speak for myself and sort of the colleagues I work directly with. Every person kind of hits you differently. It's always, no matter sort of their age, it's always a loss of life. So there's a couple of things I find personally that help me to sort of come to terms with that. It's ensuring that in those moments, whatever I could do, I did do. So whatever I could do to make them comfortable, whatever I could do to connect them and their families, I did do. And then there's also the understanding that we know that the long-term care homes were hit the hardest, and sort of prepping yourself mentally to know that no matter what you do, there will still be some loss of life. Past that, we did a lot of sort of informal debriefing with our colleagues. So we would all sort of discuss together after shift if there was anything that sort of was nagging on us, that was giving us a hard time. And then we also did have a padre who, when we came back to where we were staying, would sit down and talk with us every shift. So if something had happened, if it was the first time someone had seen a death, because there was a lot of younger medics who were on the ground and younger nursing officers, so it may have been the first time they were seeing someone die. So we were able to sit down and talk about that, debrief, and then throughout the entire experience, and even in our post-deployment, once we had left the home, we were able to be connected with mental health sort of expertise should we need. So it was a great sort of empathetic job of realizing as much as we're here to help, sometimes we also need help, right? It's a difficult experience. No one really wants to see people suffer, but we'll do our job to the best of our ability and ensure that we can make people as comfortable as possible.
And how do you try to create a sense of normalcy when not on the job? Because something has to motivate you and help you draw strength to get up and go back and do this all over again the next day. How did you try to do that?
I think it's actually incredibly important to say that our team supported each other. So our team right off the bat, at least from my unit, which is 25 field ambulance in Toronto, we had a bunch of medics from that unit, so reserve unit, who were all together, who kind of already had that baseline friendship. So we knew each other. We knew how to watch if someone was having a hard time. We sort of knew that person's baseline. So if someone wasn't reaching their baseline, if they were really sullen, if they seemed a little bit down, one of us who already had that bond would be able to go in and speak with them and sort of say, okay, I know you're having a hard time. Let's throw our mask on. Let's go for a walk. And we had a designated walking path that we could go on at certain times of day. We would sign in and out, and then we would go get some fresh air. And we would work out, and we would make sure that despite still having to be apart, we were apart together and that we could still spend that time. We're very social creatures. And as much as we needed to be apart, we definitely needed the support of our team. And I think that definitely shone through.
So this must have been a challenge for your personal life, as well as we've seen with frontline medical workers who are dealing with so much stress and at the same time having to be isolated to keep their families safe. Were you also physically distanced from your family? Were you staying elsewhere? And that must have been another cause of worry and stress. And you must have missed them during this time.
Absolutely. So it definitely was a cause of stress. I will say that I was distanced from my family since January, since sort of the pandemic started hitting Canada. I took sort of the measures to make sure that I was not interacting with my family in a way that could increase the risk of transmission. So I had given my parents a hug in a couple of months, even prior to deploying. And then once we were deployed, I was physically distanced from them. So I couldn't leave the location that I was at. And it was really only phone calls or FaceTime. But of course you worry, you know that they're going to be out grocery shopping, that they're going to contract it somehow, and they're not there to support them. So it definitely is a stressful situation. I was lucky enough that I don't live directly with them, so I didn't have to worry about bringing something home. But it still is an extremely stressful situation because you worry about them and you worry about your friends and family as well. And there's that sort of feeling of helplessness of being separated from your family, friends, and pets. But that being said, it was something that we acknowledged prior to accepting the deployment and that we still did happily. No matter, again, whether it's domestic or international, there are times that we are asked to be away from our families for months to almost years. And it's something that we have great support networks, hopefully, and we're able to take on those challenges. And with that support, even though it's virtually and a little bit distant.
And have you had a chance to see them now?
I have. Still no hugs because I'm back in the ER again. To be honest, I don't know how much they like my hugs anyhow, so it's okay. But they live close by to where I work, so I do come by and visit and do some porch tea sessions. But until the situation curtails, I'm not sure when things will go back to what we consider normal.
Right. Well, you got to see them. Okay. A little bit more about your work as a qualified medical assistant on the military side and then a licensed nurse on the civilian side. Did you find while working at these long-term care homes that you had to rely on skills from one scope of practice more than the other? Or do you feel that having this unique combination of skills helped you and your fellow deployed military staff to better integrate with the civilian staff there?
I definitely think so. As a medical assistant who also is a civilian nurse, we were actually temporarily able to use our nursing license. So I worked a full nursing scope, which is why I was able to do palliative care measures and suctioning and that type of thing. I definitely think being a civilian nurse helped. So the last time I worked in long-term care was in nursing school, but I understood the challenges of that environment. And they're very, very unique challenges that you don't necessarily encounter if you're full-time military. Not the typical setting that you would expect a military nurse or medical assistant to work in. That being said, everyone was extremely flexible and was able to sort of rise and meet those challenges accordingly and very, very quickly. But it definitely did help because when you're interacting with civilian counterparts, you're able to say, okay, I know whenever we're wearing our different scrubs and that we're going by rank and last name, but I understand the challenges that you're going through. And we speak the same medical language. Let me know what you need and I can help you. And so it helped to make those bonds. And I will say as well, it really helped even on the military to civilian side for people not to be as intimidated or as sort of scared. We're people, we have families, we have careers that we love, but we are first and foremost people. And our desire to care is why we were there. So it definitely helped to build that bond between military staff and civilian staff. And it was nice to sort of be a reservist on the in-between who had the military understanding, but also the civilian medical knowledge that was required to care for people.
Now, I know both are very different, but what do you think was more challenging, working in the ER or in the long-term care homes?
I think they're both equally challenging in different ways. In both situations, you don't necessarily know what to expect and what's sort of the requirements of that day are going to be. The homes that we were in were sort of in like a crisis stage, though. So we had to sort of start from what we would consider not a baseline and build us up to that healthy baseline. And so some of the things that you would expect to be there in an institution that's operating well without aid weren't necessarily there. So the challenges were trying to identify those gaps and ensure that they were filled in properly so we could deliver safe, confident, and ethical care. In emergency, again, we have a great team. Nursing is a team sport, so you absolutely don't do it alone. But you still don't really know what's going to walk through the door. And someone that comes in with something that seems benign or that seems sort of like a quick fix can turn into something that's very, very serious. So you always sort of have to be on edge, maybe is not the right word, but you always have to be prepared for what could happen in either scenario. But you just have to go back on your training and your knowledge and know that you have a great team to support you.
I want to draw on your experience during this mission as a military medical assistant after seeing and dealing with what happened at these long-term care homes. Do you have any recommendations? What lessons do you think can be taken from what happened so we don't have to face this again?
So what I can say is, it's a long-standing, it's a complex issue, and the underlying issues won't necessarily be resolved by the military coming in. We've known about the issues, at least in healthcare, and healthcare practitioners have said, like, these are the challenges that we're facing in this environment for quite a long time. What happened with COVID-19 is that it sort of pushed that over the edge. So it took a system that was working but needed a little bit of support to insert in certain homes a system that was no longer working, that needed a lot more support to get back on their feet. I don't have a quick fix solution because I don't believe that there is one. But I definitely think as long as we sort of value our geriatric population and that it wasn't sort of a thing that we saw on the news and then now it's gone, the issue's no longer there, I think we'll be in a good place. I know that as we all age and as our parents all age, we want them to be cared for. And I think that ensuring that we care for Ontarians and Canadians that we'd like to be cared for as they age and as they're in the last years of their life will be in a better place, and that hopefully we will learn from the COVID-19 pandemic and in all healthcare settings and be able to sort of prepare a little bit better. But no one expected this to happen. I certainly didn't. So I think people are doing their best. And they weren't. They asked for help and they got it.
It's definitely an unprecedented crisis that we're all coming to terms with and learning from. On a personal level, you were at the front lines of the COVID-19 pandemic, working from one of the hardest hit communities. How has this experience shaped you as a person and how you look at and do your job? Has it changed anything?
So I definitely, again, when I mentioned palliative care earlier, it's an environment where it's not something that often happens in the emergency room, but it definitely was something that I found a newfound respect and passion for. The ability to make someone comfortable is incredible. And it's an honor, and it's something that, while it may not be the specific area of nursing that I choose to work in, something that I will value. And even in that means in little ways in my nursing practice to make sure that people have adequate pain medication, even if they're only there for an hour or two, and make sure that people, even if it's not a pharmacological sort of intervention, that you're able to sit with them when you have time and talk with them. Obviously, there's sometimes challenges that present that don't allow that, depending on level of patients and patient flow. But being able to keep that human aspect in healthcare, I think for me now is incredibly important. It's easy to get into the swing of doing a bunch of shifts in a row, particularly night shifts where you don't really know sort of how to properly interact with people at 4 a.m. because who really is up at 4 a.m. But keeping that human aspect in there, no matter what time it is and no matter who the patient is, I think now for me, I have a renewed sense of wanting to do so.
And you're still working night shifts in the ER right now, right?
Yes, I am.
Are you still dealing with a lot of COVID patients?
I mean, I can't really speak directly to the numbers per se. There is still, obviously, in this region, levels of community transmission. Oftentimes, people will come in for testing or will come in and maybe be suspected, but I can't necessarily say, even just for patient confidentiality, whether people are necessarily COVID positive. Being in the ER, you're sort of on that very, very front line where you don't really know if people are COVID positive or not. And so you sort of have to, in a way, assume that everyone is and do your PPE practices properly. So it's really not touching your face. It's hand hygiene, making sure that you're wearing your mask and face shield at all times. So it definitely makes the 12-hour shifts quite long. But that being said, it ensures that we protect ourselves and ensures that we protect all the patients that we interact.
And it takes a lot of courage and sacrifice to be at the front line of this, as many of us have been able to be in quarantine and be safe while you're out there keeping people safe and helping them. How can we all help frontline workers like you to make your life easier during this time?
I think that it's something that we understood maybe on the very base level when we enter a profession. We understood that there are situations that we may be called upon where there presents some level of risk. And that's both on the military and civilian side. So working directly with people doesn't necessarily have to be a medical risk. We have code whites or violent patients. We have situations where we may be exposed to chemicals or exposed to gases, depending on what sort of walks through that door. So we understand that there's that inherent risk. I personally, I remember at the beginning prior to me deploying, we got a lot of the drive-bys by the police and the ambulances and fire trucks with their sirens and stuff to show support. I think just to remember that we're still working on those front lines. We haven't left. Nothing's really changed. And we're now potentially preparing for fall. And again, no one really knows what's going to happen in that sense, but we haven't left. So that support that we initially had of first responders and frontline healthcare staff at the beginning was huge. But we also want to make sure that we're still remembering that people are still working those shifts. People are still having those risks and still fearing that they're exposing their friends and family to the virus. So it's been a very isolating year for all of us, and there's really no end in sight at this point. So even though the novelty has worn off, just remember that we are still working those shifts until we no longer need to.
And I think we need to remember that you guys are still working those shifts, and everybody should abide by the protection protocols and social distancing and wearing masks to help you further, right?
Absolutely. Public Health has released sort of the best practice guidelines on how to reduce transmission of COVID-19. I know it's difficult. It's nice outside. It's our last sort of sense of normalcy for summer, but ensuring that we sort of stay track and that we utilize our masks, especially in indoor areas, and we complete proper hand hygiene, and that we're not sort of collaborating in large groups really, really is important, because it makes a difference between us having sort of a trickle of patients over time versus an entire spike. And obviously we're hoping that there will not be another entire spike, but we will be prepared if there is.
Thank you so much, Corporal Lola. I'm going to let you catch up on your sleep because I know another night shift is coming for you, right?
Yes, it is.
Thank you for your time. Stay safe.
Thank you.
That was Corporal Laila Ahmed, a medical assistant with the Canadian Armed Forces and also currently a civilian who is a registered practical nurse. That's it for today. Thanks so much for listening. This Matters is hosted and produced by me, Sabai Tazaz, Adrian Chung, and Raju Mutter. Produced and mixed by Sean Pattenden, and our director of programming is JP Fozo. Our show theme music is by So Called, and our episode music is by Mike DeAngelis. We want to hear what stories matter to you. Please send us comments, questions, or ideas to thismatters@thestar.ca. Please consider supporting the journalism the Toronto Star newsroom does at thestar.com. And don't forget to subscribe to This Matters on Apple Podcasts, Spotify, or wherever you listen to your favorite podcasts. Let's talk soon.